Morning everyone. I just had a chance to look through all the trade things before I came in, and I have to say I absolutely acknowledge you for your breadth and depth of information that you need to be across. It is not an easy job. It's quite extraordinary what you do. So anyway, this morning what I want to talk about is a national project that's actually been based on an older project that was first run out in Brisbane. So really the presentation is about a patient-centred care for palliative care people who want to die at home, and that relies on consistency of practice and information, both from carers to patients and nurses and other people in the healthcare team. But also this project shows a way of getting some time and resource management for very time-pressured nurses in the community. So what I'm going to talk about is just some background to the project, the funding, etc. What is the Caring at Home project, which is the name of it, and why did we figure it was needed, and the work that has been done and will be achieved in terms of resource development, the rollout of it, and also the evaluation. But I have to say at the start, unless we can win the hearts and minds of all the nurses out in the field, this project will fail. So in terms of background, the Department of Health last year released the National Palliative Care Projects grants, and we in Queensland actually got 3, and where I work in palliative care in Metro South Health, we were lucky enough to get 1. And basically what they're trying to do is to improve access to high quality palliative care for all Australians and to enhance the delivery of palliative care service delivery. So we pulled together a consortium, and that's had advocacy and leading bodies in the field that you'll know about, and each one of these consortium members are doing different jobs. For instance, NPS, the National Prescribing Service, is going to be writing some guidelines and an app that you may be interested in. So what is the caring at home? Basically that's all sort of posh wording, but really what we're trying to do is ask nurses to learn a standard form of teaching, and then to teach carers, non-paid carers at home looking after a palliative care patient, how to safely administer subcutaneous injections towards the end of a person's life to keep them symptom-free and allow them to remain at home if that's what they wish. We're not saying that people have to stay at home. There's all sorts of factors that impact on that, and you will know that as well. However, people in general, they all say we would like to stay at home, if not to die, then at least to stay there for as long as possible, because they're in the context of their life. They're surrounded usually by people they love. So really the Caring at Home project is trying to find a way to facilitate that to happen, because we know that one of the major causes that people get admitted to hospital when they don't want to be admitted is because their symptoms couldn't be controlled at home. Another really common reason for people getting admitted when they don't want to be is the carer stress. So both the person and the carer, they need a lot of support. So why did we figure the project was needed? Well, for the reasons that I said, but also from the earlier research that we did in Queensland, we knew that because most services, most people don't have access to a nurse 24 hours a day who can visit in a timely manner to provide symptom relief. So the only way around that is to ask carers to adopt this quasi-professional role that includes the monitoring and delivery of medications for symptoms when they arise. We know that leads to carer stress. But we also know, because we interviewed carers 2 months or so after a person had died, we know that in the bereavement phase that the carers report that they felt really empowered and satisfied by helping the person achieve the outcome that they wanted. But what they also said was that they needed more education to help them in their symptom management role. This was a quote, this isn't her, this is a stock photograph, but this is a quote from one of our carers. "We knew when the pain hit, we were able to do something to try and relieve it immediately without having to sit waiting powerless for someone else to come and do it. I believe it gave me the confidence to keep him at home to the very end." We have just finished a randomised controlled trial which will be published in probably about 2 weeks. We were getting a lot of feedback from nurses in the field, some of whom said, "You can't ask carers to do this. It's too hard, it's too demanding of them." Or we had other nurses say, "Well, what about infection control? We shouldn't be the ones doing it." So we ran a randomised controlled trial with 3 components. One component, the one to your left, the carer drew up the medications, stored them in the fridge and later administered them. In the next one, the community nurse, the one who was visiting at home, drew up the medications and left them in the fridge for the non-paid carer to administer later. And in the third arm, at great expense, we employed a clinical pharmacist with a laminar hood and blah de blah blah to ensure sterile technique, and they drew up the medications, and we taxied them out to the person's home and left them in the fridge for the carer to administer later. The dark blue first oblongs there, that is a measure of the confidence of the carers with their first injection. Now, we figured that the carers would be far more confident if the pharmacist had drawn it up under U-But conditions. But there was absolutely no difference in those 3 groups. So all the statistics showed that it had no impact on the carer whether they did it or whether someone else did it. But importantly, we could feed back to the nurses that as well, and also to let the nurses know that they're doing the same sort of a job as a pharmacist in a hospital with a laminar flow hood. Now we knew from what the carers are telling us, the first injection is stressful, no doubt about it. But the light blue oblongs there, then they look at subsequent injections. So what typically happens is once the carer is all anxious about giving the first injection, for second and subsequent injections, they're just like any professional. It just becomes routine part of the day, no problems, and they do it. So that's what that light blue one is, showing the confidence of the carers with subsequent injections, and again, no significant difference between the 3 groups. So there you go. So, so we wanted, because it was successful in Queensland, Department of Health then has given us the money to run it out across Australia now. Because there is agreement that home-based palliative care can be improved. Because what we're seeing is non-consistent anecdotal practices, and what else can we do, that causes confusion between service providers. I don't know if there's any blue care nurses here, but I was speaking to a blue care nurse the other day who works across an area that's got 3 different specialist palliative care services in it. And she said it drives her crackers because each service has got different routines, different workplace procedures, and no consistency. So always she's got to work out, oh God, you know, who's the service here? What am I supposed to do? There's also a lack of community-based resources to meet demand. The demand for palliative care far outstrips what's being done out there. And that leads to very poor patient outcomes, not to mention system outcomes, and often people go to hospital when they don't want to. One of the other problems that the nurses reported was people weren't sure of the legality. How do I carry drugs? Am I allowed to draw up a patient's drugs? If I'm using drugs that belongs to, say, the service, does that make any difference? How do I store them? How do I get rid of unwanted medications? So all of these things are sort of constraints acting on nurses. So what the National Prescribing Service is doing for us, and they're the peak body, using the guidelines developed in Queensland, they are doing jurisdictionally specific for each state and territory a set of guidelines. So everybody's got a guidebook there, the most incredibly boring book you'll ever read in your life, because it's you must, you may, you know, blah, 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 but it is all there. And so for whatever service you're working for, it gives them that medico-legal security to allow you to act in this role. So who's the target audience? As I said, it's really all about the nurses. We are targeting the nurses. Secondarily, we will be targeting organisations and GPs and pharmacists, but our primary target are registered nurses, the nurses who will be teaching the carers how to administer the meds wherever they work, whether that's in the community, or sometimes carers get taught before they're discharged from hospital. So what have we got to do? Basically what we've got to do is revamp the resources that we used in Queensland. Then we've got the very difficult task of implementing and rolling it out, which is all about comms and media, of which I know precious little, but we've got an Energizer bunny who's just joined the team, and they're all into social media and I can't even spell it. So we'll be relying heavily on her, and then we evaluate it to see whether it worked or not. Now, I don't know whether any of you have seen this. This is a picture of the guidelines endorsed by Queensland Health for use in services across Queensland. Have you seen it? Have you? Great, good. So we will be updating that and making one from whatever state or territory you come from. The other thing is reviewing all of these standardised and consistent resources that we had both for nurses and for the carers. Up here, and you can't see it very well, this is a demonstration kit in a little takeaway container with a dressing on top, and in it there's ampules containing water and syringes, and then so that the carer can practice under your supervision, can practice opening the ampule, and even that, you know, that's a skill. How many of us have, you know, cut our fingers and whatever, opening the ampule and using a blunt needle technique, draw up the medication, put it into the syringe. And to help with that, people have got different ways of learning, but probably the most successful way is one-on-one with the nurse. That's what we keep hearing from these carers, that's the most important part of their learning. But also we have these pictorial guides of what to do. We'll be having little videos of those. Then the drawn up syringes need to be labelled with these specific labels to keep this all safe. This is the Australian and New Zealand anaesthetic labelling guide. So they're all quite prescriptive about that. And then also there is a diary for carers to fill in each time they give an injection. So what we're asking people to do is say, what is the level of pain before you gave the injection? What's the level of pain after the injection? So that way the carers can monitor it. They also know how much medication that they've used. The carers get so stressed out. Often I say to a carer, oh, you know, how many breakthroughs did you use last night? And they, oh, was that last night or the night before? You know, so if they've got it all written down, it just helps them to know, but also it helps you and it helps the doctors to know when to change medications or whether they're hitting the mark or not. And this little jobby here is a fridge label just to help colour match with the drawn up injections in the fridge. Because we're a multicultural society, several of these resources will go to will be translated into 5 different languages. Now, what have we got for nurses? And I just realised I'm about 5 minutes out. We need some online education for the registered nurses. There'll be 3 modules that you can get CPD with, and they will all be up on Care Search, and we'll give information to other healthcare professionals about what we're doing. An app for prescribers, particularly for GPs, nurse practitioners. We've got pharmacists there, they're the dispensers, but they're important in this too, about everybody giving the same information. Of course, you're welcome to this app, but again, it's a bit of a boring app saying what's on the PBS, what ampules are on the PBS, etc., etc. And we have a list of 8 medications endorsed by the Australian and New Zealand Society for Palliative Medicine, medications that are used consistently across Australia to manage symptoms, so people can get familiar with those drugs. And we'll be doing workshops for people, for RNs in rural and remote areas who maybe don't have the same sort of access as other people. But then once we've got all that there, and that should be ready in November, then we've got to start on this very extensive multimedia communication just to let people know that it's out there, and also to see whether they want to do the modules. The important thing is the translation into practice, and really this is where we will be getting onto the organisations to tell them about the guidelines, also to give them templates for organisational policies and procedures. We've got a website, of course we've got a website. We've only got a splash page at the moment, but that will be opening very soon. And we will be providing phone support and other indirect support for people throughout the country. So, sorry, that was a mistake. So this is the splash page, and I think that's probably all I need to say. How am I going for time? Good, excellent. So thank you very much.